My name is Yoav from HealthIL. Just briefly about myself, and then we'll get into it. This is a special session we're doing as part of HealthIL Week. Our main event was yesterday. We have some incredible panelists, and we're going to be talking about a area of care that's actually very near and dear to my heart, which is children's health and technology, and where startups and innovation can help address gaps in care of technology. With me today is Todd from Cincinnati Children's, Andrew from Great Ormond in the UK, and Patrick from Schneider here in Israel. They will introduce themselves shortly after I give kind of a brief overview of what's going on. So first thing we're going to do a really brief introduction. I'll do it in about 5 minutes. And then we're going to transition to our panelists, where we'll talk about three things: the challenges in caring for children, where startups and technology can help, considerations for these startups, and we'll close with some Q&A. For the purposes of Q&A, soon you'll see Daniela from HealthIL here in the room with us. When you have a question, please write it to her directly. She's going to aggregate the questions for our Q&A. If you have a question specifically for Todd or Andrew or Patrick, make sure you highlight in your question for Patrick, question for Todd, whatever, or if it's for everyone in general, great. So to begin with, I want to address three specific things. One of the things that's really important that frequently gets overlooked or at least forgotten about is that innovation for children's health is not about finding some drug for some rare disease. I had a conversation with an investor yesterday who said, well, we don't invest in children's care because it's very narrow and it's all about, specific rare diseases that have a small market. And I countered, that's not what we're looking at. We're looking at technology that can help throughout the entire spectrum of what a child is. The other thing is that there's very large kind of global challenges that need to be addressed, based on a lot of research that I've read seems to kind of converge into a number of very key topics that are going to be relevant over the coming decade or so. One would be mental health for neurotypical children, depression, anxiety, etc. Shield, mute yourself. The second would be developmental issues for neurodivergent children. That's where ADHD and autism things fill into that. Obesity, nutrition. There's quite a lot of challenges around infancy from ages 0 to 2. And then there's a lot of challenges for parent and caregiver support, specifically when the child is the recipient of the care intervention. The last thing I want to mention about this, if people could please mute themselves, that'd be appreciated. The last thing I want to mention is that the term children is frequently misunderstood, right? A lot of the innovation we see, at least here in Israel, relates only to a specific subset of what a child is. And we want to kind of challenge ourselves to think much more broadly throughout the entire spectrum of 0 to age 18. And as this child progresses in age, the challenges that the child faces also change. So just a highlight of what's going on here in Israel. And I'll be frank with all of you. I think children and healthcare and technology and startups is probably the biggest missed opportunity in Israel. Israel as a system, I think, is very uniquely positioned to serve as an incredible infrastructure for new solutions. And there's a couple of reasons for this. The big main reason is that pediatric care, general practice, or what we call in Israel family doctors, are highly utilized in Israel, especially as compared to America. It's an incredible touch point that happens very, very, very frequently. The second thing is that these touch points are robust. It includes vaccination, growth and checkups and visual and dental and quite a lot of these aspects. This creates a very interesting and rich potential for care continuum, really from 0 to 18, from birth until adulthood. I personally think that this is a resource that is barely being touched, and we're barely scratching the surface of potential here in Israel, what can be done. That being said, There's a lot of aspects of children's care that are frankly not being addressed in Israel, at least by the startup community. Mental health is a major gap in care. And also, we're not seeing a lot of stuff that's kind of age 10 and up. We're also seeing quite a lot of saturation in ADHD and autism in neurodivergent solutions. This creates a problem because it's very hard to create differentiation between all these startups. Funding across the board for children is scant. That's a whole different topic. We can talk about it at the end. But the point is that Israel has an incredible infrastructure that isn't being utilized, in my opinion, to its fullest potential. And so hopefully in the coming years, we will see more startups utilizing the Israeli healthcare system to address these challenges in care that children face in the coming decade. So what we're going to do now that I've given this background, I really want the panelists to introduce themselves. Please share with us briefly who you are, where you work, a little bit about the organization, what it specializes in, and then we'll get into our questions. So I'm going to stop my screen, and Todd, I would love to begin with you.
Thanks, Yoav. It's great to see everyone here. So I am a pediatric surgeon and have the dubious role now of being the VP of Innovation at Cincinnati Children's Hospital. Our organization has been primarily focused on inside-out technology. We have a robust research arm. It's a $5 billion endowment with about $500 million a year in spending of US dollars. And so all of our innovation has been focused on getting our technologies out as opposed to looking at better opportunities of what might be on the outside in. That's been a big gap of ours. Our asset categories are the typical ones that you see at university academic medical centers, which is device, digital, heavy in biologics and small molecules or therapeutics. Our hospital is a quaternary care center. So it is really an acute care center for highly specialized diseases. We can get into more detail on some of our more recent priorities as far as child health and where we see to stand in the future.
Great. Moving on to you, Andrew. Same question. Tell us about you, the organization, what you're seeing.
So hello, everybody. So I'm Andrew Taylor. So I'm a professor of cardiovascular imaging. Seems to be a theme here. Anyway, by the by, but I'm also the director of innovation at Great Ormond Street. So Great Ormond Street Hospital for Children is a standalone children's hospital in the United Kingdom. We would see lots of specialist care. So we have 63 specialties. The only two things that we don't do are liver transplantation in children, which is done elsewhere in London, and we don't have an emergency room. So actually many of the common conditions that you've listed, we would not necessarily see. Having said that, 5% of our admissions or 5% of the work that comes into us is emergency, but will come from another hospital. So into our very large pediatric intensive cares or cardiac intensive care units and a specialist neonatal surgical unit. I think so. Similarly, we have historically had a huge amount of research, which has often driven through our university partner, the discovery of that. And I think what we've tried to do over the last 3 years with innovation is really work out what the problems for the organization are and develop and work with new ways of addressing those problems. So particularly around digital, we also have a expertise in what we call drug discovery, which is around cell and gene therapy, but particularly around those two areas, and particularly around data and particularly around AI and machine learning, to try and see if we can. What I often say is there's lots of great ideas, there's lots of good people, but almost nothing getting implemented in day-to-day care. How do we bridge that gap? And that's what we're trying to do. So super specialized hospital, very similar to Cincinnati Children's, but without an emergency room.
Thank you, Andrew. Patrick, moving on to you. Please tell us who you are and a little bit about Schneider.
Thank you, Yoav. So first of all, thank you to you, Yoav, and to HealthIL for a fantastic congress yesterday, which is really encouraging, seeing the difficult times that we're going through at the moment in Israel. Um, I have a soft spot, as it happens, also for GOS, having trained there, and for Cincinnati Children's. I'm a pediatric pulmonologist by trade, and my role models and mentors include Colin Wallace at GOS and Bob Wood at Cincinnati Children's, where I spent considerable amounts of time. So in terms of innovation, I would like to quickly point out a program that I was privileged to participate in, which is basically a subspecialization in healthcare, health technologies, and entrepreneurship. Something that was started a couple of years ago by the Israeli Medical Association, and that invites senior doctors to actually get hands-on training for a whole year and everything that's to do with innovation and entrepreneurship. And as a result of that fellowship, I was able to integrate into our innovation center at Schneider Children's, where I play the role of chief medical officer. So similarly to the other two hospitals, maybe on a slightly smaller scale, we are a tertiary hospital that caters for all subspecialties, including liver transplantation and emergency rooms. And we have funding for innovations, which is very far from what Todd was pointing out, maybe closer to zero, and we have to kind of make it up as we go. The areas that we deal with are also digital medicine. We're trying to integrate artificial intelligence into our workflow, which is also proving difficult, and the implementation aspect is something we're struggling with. And this is maybe a good point in the discussion to just point out that we have, as International Children's Hospital, there is quite a lot of collaboration going on, which is addressing some of the deficiencies that you have pointed out, Yoav, in your introduction, and part of this is the global ecosystem organized in an organization that's called KidsX. I see our colleagues from Malin in Israel are here; they're also part of it, as are GOS and Cincinnati Children's. And basically, this is like a platform of leading children's hospital that is intended to help accelerate healthcare innovation across the board and to try and transform care.
Great, thank you, Patrick. So let's begin. And actually, Andrew, I want to start with you. And you know, at the highest level, there's a lot of challenges dealing with children, right? There's many aspects that are unique. There's many stakeholders involved, and there's always a parent involved. So I want to start with you, Andrew, and tell us a little bit about kind of what are the challenges you see with your patient population now, and give us an example of what you think will be the most critical challenge and why in the next 5-10 years.
Okay, so I thought what I did partly around the sets of titles that you've given is just give you a bit of a UK feel. So actually, if you look at mental health, 82% increase in acute hospital admissions for children with mental health since the pandemic. And that doesn't touch on all the other issues that we know that are going on. 22% in our autism referrals. We have in the UK, 28% of the childhood population are obese. And from a parent and kind of family perspective, 19% in the UK are probably living below what we would describe as a poverty line. So huge numbers of problems. Asthma's on the increase because of the pollution, so on and so forth. So lots and lots of things. I think from us as a specialist environment, what we're seeing is actually that the number of children, the prevalence with life-limiting and life-threatening conditions in children and young people is really, it's increased by about 40% every 10,000 over the last decade. And so what we are seeing, and what I would say our fundamental problem is that we've got more complex patients, we've not got a budget and funding that is growing to deal with them, and we don't have the expert clinical staff that we can access to be able to deal with these problems. So fundamentally, at best, we've got to do what we're doing even better with the same resources. And although that's a very generic problem, I think that's a great thing for innovation, because actually in a pediatric environment, you can test lots of things that aren't pediatric specific. So if you can make them work in our environment, and I can give you an example in a second. If you can make them work in our environment, they are you can translate them into the adult environment, which clearly in a startup world where commercial and not only the value that's benefit to the patients, but to the clinicians, but also a commercial value is important. That's really important. We are not a niche thing, though often we're seen as it. However, the other thing I would say is what we see in the UK is almost all the funding goes to adults, because that's where the real pinch points are in all the things that on a political and governmental level people are dealing with. So it sounds slightly trite, but I will say it, and I'm not sure we've kind of got this across to policymakers, is 25% of our population is pediatric. They're 100% of our future, but we're not investing in them. So somehow we've got to break these cycles. And then the final bit for me is I think we kind of envisage a new model of care, don't we? Where I just give you an example. Why do we pick that I see a patient with an atrial septal defect regularly as an outpatient? Actually, some of them I may never need to see again. Some of them I may need to see on a weekly basis. So the opportunities for us are really how do we make what we're doing more patient specific so that we can keep that people in the background at home where we've still got oversight on them, but those patients we really need to see to deliver our expensive care and our treatments, we're making sure that we're really targeted and focused on those people. And so for me, that's that I'm not being very specific there, but those are the fundamental problems. And if we can begin to solve them, and I do believe technology can help us in some of that, that's going to be really important. My final bit is, I think, as Todd sort of said, we're trying to become, I guess, what's called open innovation. So people with ideas coming to us. What I find, though, is that's not about what's the next shiny toy. I really do. So I often see innovation as a dating agency. I need somebody with a clinical problem, innovation to facilitate how that might work and take people through some of the processes, whatever that may be, but often somebody to help us with that novel solution. So that's kind of where I see us at. But for me, those are the issues that I feel pediatrics as a whole really faces.
So I have two follow-up questions for you, Andrew, right? The first is that you mentioned complex patients who are children, right? There's a tendency to think of complex patients as, comorbid elderly patients. Can you define for us what you mean by complex children?
Yep. So on average, the patients that come through our doors are seen by 9 separate specialties. So you might be a cardiology patient, but you will be seen by lots of other people because you've got many of those comorbidities, whether that's related to a genetic cause, whether that's for a whole plethora of reasons. Occasionally, you'll be seen by one specialty. Sometimes you're seen by not far off 40 of them, and which is weird, I know. And that probably can't be an efficient model for making these things work. But that's what we see in our patients. The other thing that we really see, and you talked about that whole age spectrum. So as a hospital, we will see new patients up to the age of 16, and we'll see if you're in our system before 16, we'll see you to 18. Slightly weird, but those are our rules. This transition period, particularly if you are in this really complex world, how on earth do you do that? Most adult services are dealing with 70 plus, and suddenly here's an 18-year-old who's got many, many problems from a neurodiversity perspective to a cardiac condition to a renal condition. Who's going to look after them? Where is that skill set to do that? And so you talk about that whole pathway, but we often many of our patients we will be seeing through that lifetime, 0 to 18, through that journey. So these are complex patients. They've got a lot of comorbidity.
So the other thing I want to bring up briefly before we move on, you mentioned this 19% is in poverty, right? And I was looking at some interesting statistics from the Royal College of Pediatrics, and was specifically looking at obesity. I forget the exact numbers, but I think it was about a third of children who are age 6 are obese in the UK, who are in kind of the most deprived areas, all the way down to about 10 to 12% in the least deprived areas. Why was this interesting to me is because the NHS is a national system. Every child in the UK gets theoretically the exact same basket of care. So how does socioeconomic aspects play into these challenges? Are you seeing different challenges with children in this socioeconomic space as opposed to this socioeconomic space?
So yes, so even if we look at the simple thing of COVID vaccination, huge differences related to cultural beliefs, how people feel that they should access healthcare. I think we had a phrase which was we've got some populations that are difficult to get to. Actually, that can't be the case. It's not that they're difficult to get to, it's just we're not reaching them properly. So I do think there's huge amounts of efforts for things that we're beginning to understand around health inequalities. And actually, there's a real push in the UK to be able to, we have to be careful what we judge as what is a measurable health, what causes health inequalities, but there are certain things that we can clearly look at. So in the UK, we call them postcodes, Americans call them zip codes. Every one of those now has a deprivation index around it. So we as an organization can now look and say, actually, these are the differences. How do we do that? If you just look at patients who do not attend for clinics, what do you need to do? Actually, it's really clear. Some people just can't afford to travel to the hospital to come to their appointment. So actually, you have to think of a new model. How do I either facilitate that by providing transport or support them financially so that they can get the healthcare that they need? And so and again, through some of the data that we're doing and the way that we look at it, we begin to expose those differences. Once you know what those, you do that kind of data discovery, you can then work out what your solutions might be. It's clearly there though. And, as I say, we saw it a lot in COVID vaccination and uptake, similar sorts of groups. And it's just how we get our message out, how we explain the importance of what we're doing and why these things need to happen from an educational perspective.
Great, thank you. Todd, I want to move on to you for the US perspective. And my question is very simple to begin with. What challenges are you seeing for children in the US, in your population? What do you think is going to be really the biggest issue in the next 5-10 years in the United States and for your cohort of patients?
So we are incredibly honored in the United States to have the absolute worst healthcare system among developed countries. So we are so excited about that honor. We have access to care problems, incredible disparities in care. The rich get better care than the poor. The working middle class get the absolute worst care. So our organization is recognizing that as probably the #1 problem to solve. How can we distribute and provide the best care for everyone? And that's #1 example of that is access to care. How can we solve the problem of access, which is for us a huge thing? And a lot of that's going to be with a lot of technology solutions, remote patient care, things like that. Everything that Andrew said is the same with us as far as in the United States, mental health is our absolute medical problem that we're trying to solve. And, everyone's like, this all happened after the pandemic. And my thoughts are that it didn't. It's just that the pandemic made everything more apparent. So I think all those mental health problems were there. It's just that we became more heightened awareness of all this. And it's so much of a problem that honestly, there's backlogs of medicines. You can't get the medications because there's so many people that need it. The medicines are oftentimes a primary resort where we should be developing solutions to mitigate the mental health before it requires medical therapy. Patients can't get into the hospital. So mental health is #1 for us. We're also, we have a big problem with fetal medicine, and that's why for us, fetal care has become a high priority. Nutrition obesity is a pandemic for us. We're trying to get ahead of that, again, not with just therapeutic options, but mitigating the disease before it takes hold. There's social inequities with food insecurity. People just can't get the food they need. I would say that those are our biggest problems from a healthcare status. We also, from an innovation standpoint, yes, same problem. It's not that the country is ignoring it. It's just that the financial model is not there. They're rare diseases. They're small numbers of patients. So trying to create a technology that that's just gonna make it to market doesn't go. And so that's why we're looking for novel ways of getting these technologies out there. For example, we are now opening up the doors to say, if you have a great adult solution for mental health, we'd like to work with you to look at pediatric protocols, pediatric algorithms, and how can we provide the pediatric angle to that rather than thinking everything needs to be our own independent solution. That probably is where things are failing for us. And I'm excited to see that
I found this
others around the world are kind of doing the same approach now. It seems to be a new concept. And the other thing is this type of forum. I mean, and Andrew and I are part of another thing where we've met each other through iSpy and then KidsX. I am finding the most momentum by working with other organizations. Innovation is exciting because there's no posturing, there's no egos. And so this is where we're going to excel by saying, all right, we're looking at this technology. What do you 10 friends of ours think, and should we do this together? That's kind of our approach. The other thing is that what Andrew said is we recognize where we're not good. We're great at some things, we're not good at others. We're not good at launching companies very well. We're good at licensing our technology, maybe. We recognize that now. So let's partner with people that can work with us to launch. Also, we're creating an unmet need-based approach. So instead of just waiting for tough stuff to come to us, we say, all right, this is a big unmet need. Hey, Andrew, Patrick, Yoav, do you guys all agree that this is an unmet need? Let's do this from the beginning and come up, see if there's solutions out there. If not, let's develop this together as a kick-butt solution that we are paying attention to the market from the very beginning, so we have the best chance of getting it out there, translated to the bedside. So those are, I guess, in quick summary of, I don't know if that answers your question, but that's sort of our thoughts on it.
So I want to ask you a follow-up, right? Because you started off saying the US is the worst system in the world, right? And, in that sense, it's very different from Andrew at the NHS and Patrick and I here in Israel. And when you think about the United States, I could have a child whose parent works in the Bay Area for Google, and he will have a basket of services from the employer, which is going to be radically different than a child on Medicaid in Tennessee. Right?
Yep.
So are you seeing differences in the types of challenges that these two cohorts have?
Yes, but I'm going to actually challenge that. I'm going to push back. You said you wanted some heat, so I'm going to bring heat back to you, Yoav. I actually don't think it's the Medicaid patients. They get care. It's the working middle class. So it's the underinsured in our country.
Underinsured. Yeah.
Yeah.
Okay.
So what happens is we opened up in Cleveland. I'm weird. I work in Cincinnati, but live in Cleveland. But in Cleveland, we opened up this free care clinic. Just come. Anyone, if you need care, come. By the way, the most common thing people came for were eye care and dental care. That's where they were getting no support. It wasn't those on Medicaid. It was those who couldn't afford good insurance, and that's the underserved population in our country.
Okay, excellent. So Patrick, now moving on to you. I would love to know what challenges you're seeing here in Israel. What's going to be most relevant in the next 5-10 years.
Thank you, Jan. So in Israel, we actually invested a lot into setting up digital data sets maybe 30 years ago. And we have very detailed information about people who are now adults, how they started off in their childhood. And theoretically, we could follow through. But this actually ties up with the challenge that this poses, because in principle, we should be able to have great offerings for startups looking to understand the evolution of any disease you can think of from childhood into adulthood. But the question begs asking, why is this not happening? Why not more startups sort of tapping into that very rich potential? And I think the challenge is really that we have the infrastructure, but it's not really aggregated in a well enough defined way. The various data silos are in disparate places, and they're not unified. They don't speak the same language, and it actually requires quite a lot of manual work in order to go and figure out, to clean and to scrub the data and to put it all into one so that it can be interpreted. So I think there is a lot of potential that is still that is still untapped. That's the one thing. The other thing is, we have a lot of creativity in Israel and a lot of people who want to do things, but the return of investment for young startups is very often in pediatrics much further down the road than their runway allows. So, we pride ourselves in being able to change the trajectory, and I think this paradigm of trajectory is very central to what we're doing in pediatric healthcare. Because if you're able to affect the behavior of a teenager or of a young child or of a family with regards to lifestyle choices, medication adherence, treatment monitoring, everything you can think of, really, then you have a huge benefit further down the line, but this might not be measurable until maybe decades later. And whilst it can be of huge benefit to the healthcare sector and to the economics of the country, the startups cannot translate that into ROI in the short term. So I think these are some of the challenges that we have to deal with.
So I want to ask you a follow-up question as well, right? And you and I live in Israel, and Israel has something very, very unique in that there's this population base where certain groups access care in totally different ways. Like the base underpinning, the actual basket of care is the same, much like Andrew in the NHS, but we have certain demographic groups that will access that care radically different, like the ultra-Orthodox or the Bedouin or the Druze. Are you seeing differences in the challenges that children face across these demographic groups?
Yeah, thank you. For sure. I think especially when it comes to digital medicine and to using devices, we often find that when we deploy various technological solutions, they will be used by those who actually are privileged to begin with and who need them less. So how do we get those tools and how do we get advanced technology into the houses of people who are a priori less inclined to make use of them? And I think this ties up to like a general philosophy that I believe is true in health, altogether, which is, we're all trying to save costs and write benefits of technology, but at the end of the day, you cannot divulge the element of human touch, and successful solutions will eventually always be hybrid. And to reach those disadvantaged segments of the population, you're always going to have to invest more manpower and hours and people who reach out and who do the onboarding and who actually very, very actively accompany those disadvantaged segments of the population.
Great, thank you, Patrick. So I kind of want to move forward with this right now that we've discussed all these issues. I want to actually discuss possible solutions. We'll change up the order. And my question is this: given all of these challenges and these issues with caring for children, what has been working? Have you utilized some startup, some external technology, some external or internal innovation to address a challenge successfully? And the follow-up to that is, in order to be successful, what does this startup need to consider? So let's switch it up. We'll go with Patrick first.
Okay, so I could think of an example that we've pushed over the last couple of years in the Innovation Center, which is a respiratory solution for children with asthma. Talked about asthma affecting 10% of the children, chronic disease. And one of the highest goals, I think, and one of the soft spots that we have to reach for in pediatrics is to be able to affect change in terms of self-management and to teach children to take responsibility about their own disease. This will reap huge benefits in the long run. And what we've done is basically we've used a digital kit of home devices, which consists of a digital stethoscope, a spirometer, and an oximeter, supplemented by an app that integrates a symptom score, questionnaire. And once a month, children and their families are encouraged to send us their measurements, and we're able to look at their various the constellation of the signs and the symptoms, and be able to direct them what to do. And what we've seen is that the children actually quite like to take control of their own disease and to see where they're at and to have a feel of the trend. What is the lung function doing? What is the symptom score doing? And in this way, we're able to transfer some of the responsibility from the care team to the child and to their family. And I really think that this is, the educational value, which is being achieved by implementing these technology tools, is immeasurable when it comes to long-term outcomes.
Wonderful, thank you. Todd, off to you. Same question. Have you actually succeeded in using any kind of external tech or external startup to address a challenge? And what do you think's kind of, in order to succeed, an important consideration? Todd, you got to unmute yourself.
Sorry, we have, but not in a measurable way. That's why we're building this outside-in component. We have not done challenges. So basically, the way that technologies have made their way into our organization is they find a clinical champion, they call them up, they say, oh, that sounds great. It goes through purchasing, and it gets implemented into the organization. The problem with that is a startup needs a very different approach to integration into the hospital as opposed to the way purchasing handles established companies. And so, number one, we want to identify our challenges. We're looking at two tiers of challenges. One is at the strategic level. We have been not aligned with strategy of the organization. So if the leadership tells us, look, these are our 10 biggest problems, we're developing a sort of a scorecard matrix to sort of prioritize those problems. How do I identify which one is the one we should be going after first? Is it the financial impact? Is it mortality? What is it? And once we identify or prioritize, let's say access to care, we need to figure out how to not have such long wait times in the emergency room, so on and so forth. Let's say that's it. We do a call. First of all, we have to figure out how do we do that call? How do we let everyone know? There's no great platform out there to just say, here is our call, and literally all the right people would see that. Maybe LinkedIn. I don't know the best way to really do a call. We've talked about paying for scanning capabilities, but then you only kind of get their own focus. You can work with venture capital to see who's in their portfolio. We don't know how to do a broad scan and capture a wide net. Then we need to go through a process of how do we validate which ones are the ones we would want to work with and which ones would best solve our problem. Because there's two separate things. One's financially driven, is we're going to co-develop with them, who's the best co-development strategy, and then also which one solves our problem best. And then we're building a specific team that is going to be responsible for the silk glove treatment these startups will need to get into the organization, get good pilot data, and then work on making it part of the whole organization as a whole. Up until now, it's clinician driven. We've seen incredible technology in all of the spaces that have been described. For example, I'm a surgeon, so a lot of stuff in the operating room. Our interventional radiologist identified some augmented reality technologies. Our physical therapists have identified great technology out of Israel that they want to incorporate. But I don't like that process of it just going straight through the clinician. There needs to be a front door. There needs to be an evaluation process that integrates with all the other arms. We don't have that right now.
Great, thank you. Andrew, and finally, you tell us about your experience with startups, what's worked, what are certain considerations about it?
Okay, so the one that has worked for us is working with a small AI startup in the UK. So one of our problems, and I think for all of us, is electronic patient records are great in that they get good quality data, potentially, into the right place, structured data. They are a single point where you go and find everything. That's great. But we know in general, clinicians hate them because there's so much more work, and there's this whole thing of it being such a cognitive challenge to complete electronic patient records. Similarly, when you're in an outpatient clinic, you're often, as we all know, when you go to the doctor, you're talking to a computer and not actually the doctor or the nurse or the allied healthcare professional anymore. So with that problem in mind, this is a company who have got some ambient technology and a large language model. Again, relatively simple in many senses. It creates so the idea here is that you don't type anything. You sit in the clinic and everything goes to basically a transcription, so that's all recorded. But at the end of that, the large language model and their technology creates a discharge, creates the clinic letter instantaneously. So we've kind of we did that as we've done this partly because we needed to take our organization through actually how you might onboard AI, clinical governance around AI, all of those sorts of issues. So we've done that in the background. Also commercial issues, we've taken legal advice, so that was also very useful. So we've done a sort of phase one of this, which was to create a minimum viable product. We've then worked, so we have a dedicated unit from an innovation perspective called the Drive unit, which we've been able to then work to see if that process works. So 8 clinicians, 46 actors who pretended to be children, ran through that process. We showed that we put in Epic, and our quality of our clinic letters, there's something in the UK called the sales score, was about 46%. That dramatically changed with this process. Clinic letter was much richer, much better. Everything was included. We reduced the consultation time by 25%. So because you take out so the face-to-face was the same, but you don't have to do all the typing. So you could potentially get an extra patient per clinic at least. So there's an efficiency cost to deal with our waiting lists. And from a patient feedback perspective, infinitely better experience because they were talking to somebody as opposed to this person talking to a screen. We're about to do what will be our phase 3 study, which we've just started, which will now be GOSH patients and GOSH clinicians. And we have gone to the National Health Service and said, actually, this should work for general practice, mental health. Would you fund a trial for us? So we're just currently doing that. So that's over 9 months we've done that. It's been a very good experience. We probably had 6 or 7 didn't works with companies as startups before that. I think why this has worked is there's very good alignment. We have worked hand in hand, and we've got a real purpose that we all wanted to try and deliver on. So I think those are the things that have made this work. So that's the one that we've done.
Wonderful. So I want to make sure we have time for some questions. We actually received 3 great questions. I'm going to let whoever wants to take a stab at it, go for it. And then at the end, please share with all of us how people here in the audience can get in touch with you. So my first question that we got was how you all mentioned this gap between piloting and implementation. So the question is as follows: how do you create that implementation of new technologies in hospitals and get clinical teams to cooperate with this external innovation or startup?
So you have to have a clinical person involved. So we run a slightly different thing, which is called the Clinical Intelligence Unit, which is really about how we get data so that people can use the plethora of data that we now have to drive decisions. And in order to have, like Todd has described, we have a funnel for how we do that, how we judge whether that's aligned with the objectives of the trust, so on and so forth. One of the bits to get through that funnel is whatever data we bring forward that will enable you to make the change, you have to own and you have to take forward. So actually it puts the onus on the person who's driving the process. And then if I use our AI model, then we have complete organizational buy-in very early. I guess the difficulty often for innovation is what you don't want to have is a sort of we've done this great thing, hip hip hurrah, here's my handoff to somebody, because they just go, what? Go away. But it's judging when you involve people. So, about 2/3 of everything we do will fail. I don't want people to be involved in the failures. They can stay out of it. But at what point do I kind of go, I think this is going to work. I need to involve people. And as an organization, I don't know what not only do we have innovation, but we also have clearly transformation. And I think for me, transformation is about the change piece in an organization that's going to accept the new things. And how do you do that? And that is super, super important. And the link between us, we're not unfortunately the same department, but the link between us is something we're really working very hard on, of what is that sweet spot where we get people involved so that that buy-in is there. As I say, in the data world, we've kind of solved it because we've got people, you have to own it if you're going to ask us for data to drive your decisions. But in the innovation world, it's a little bit more complicated and we're not truly there. But that's what our sort of solutions have tried to be. But it is hard.
Great,
So,
thank
so
you.
if I may add, we have found actually that there is a huge divide between innovation and implementation. And whilst in the innovation process, you clearly need a very active clinical champion in order for this to take off. And you need a creative startup that is sufficiently funded for the POC and for the very early pilots that you're doing together with them. This is a completely different world from the implementation world, and usually by the time the technology companies arrive at the stage of implementation, they're much more mature and they have various levels of clinical trials under their belt, and they have a product that is working and that they can actually offer. And the part of the organization that then deals with implementation is really, at least in our case, we're part of an HMO, and then there are logistics departments, and there are various clinical equipment and standard committees that take care of the implementation. So we see ourselves as much early in the process than in the implementation.
Wonderful, thank you. So I have another question from Shmuel. Let me make sure I get this correct. What is the role of government and regulatory authorities in creating these new opportunities for children health and technology, and improving accessibility for children from poor or low income groups? Effectively, if I can translate freely, Shmuel, is there anything from the government or the regulatory side that's helping with increasing access for children who are lower in the socio-demographic scale?
Not yet.
Well, Andrew, you mentioned this before, that there's a
Yeah.
big disparity about where the money's going to.
Yeah. So, I mean, I think from there is a increasing bit of process that we have to go through, which is actually now clear for people. So they know we have a thing called DTAC for anybody who wants to do, and for AI things, we have something called the DCB 1600 or something that you have to complete. But actually people now know what they need to complete to be able to take things forward. And then clearly, particularly in the worlds that we're interacting in, many of these things are going to be have the potential to be medical devices, and there's a whole plethora of processes that people will have to go through, whether that's through, in our case, MHRA, I guess FDA for some of these. So, but from an inequalities perspective, I still think, in fact, we have a thing in our organization at the moment that, as I've alluded to, that unfortunately childhood is almost an inequality at the moment. And we need to write that and advocate that children need investment.
Yeah. So
just as an example, there was the NHS put out a call at the end of probably about 2 years ago about virtual wards. Virtual wards there were only two types you could apply for funding for, both in adults. One was care of the elderly, so fundamentally preventing falls. The other one was respiratory, so fundamentally COVID wards. Nothing for pediatrics at all.
No, I agree with you. It's an unfortunate state of affairs that Patrick and I also are very familiar with here in Israel. So I have one last question for all three of you, and then it would be greatly appreciated if you could share in the chat, Patrick, Andrew, and Todd, the best way to get in touch with your organization via email for everyone here. While you're doing that, I'll read off the last question, which is, does your organization help young external startups get funding beyond the government grants or whatever, et cetera, et cetera, et cetera? Like, does CCH or GOSH or Schneider actively support with the funding process beyond what's out there? Todd, we haven't heard from you, so I'm going to pick on you.
Yeah, let me tell you the thought process behind the funding. So the number one, and is that we believe the best way to work with a startup is that if it is integrated successfully into our hospital, that is one of the best launching opportunities of getting it elsewhere, especially if we do this as a consortium with multiple hospitals. There's nothing better than saying, we have now implemented this, here's our pilot data, blah, 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 blah. We have two mechanisms of how we engage with the startups. One is co-development, that we would look at an opportunity to bring it in. To be honest, my question for the startups here is, how many here would be willing to, so part of my challenge, I'm gonna have to make sure I get back. Part of my challenge is to be financially sustainable. And I have to make sure that innovation continues to thrive by staying alive financially. And yes, we are here to support translational and mission-based stuff, but we also want to bring in revenue. So one of the trade-offs would be, would someone be willing to work with us in warrants, in some sort of shared equity, if we do this co-development? So that's one. Two would be secondary follow-on funding. That comes in if we believe from a validation valuation standpoint, we say, this fits in our strategic goals. We believe in this company. We think this is a sound investment, and we put money into it. So we have both two different arms of the organization. The funding team is different than the co-development team, but they do work together as we're building that corporate venture arm. And then but we're eager to listen to what's out there, both reactively and proactively. And the comment that Andrew said about clinical involvement, by the way, Ohio State published a paper showing that measurably involving the clinicians is financially better for the organization and retention, all of these different reasons. So, but it's bi-directional, having physician and clinician involvement in outside in and clinician involvement in inside out. So that's a huge thing to figure out how to do. You need to incentivize them somehow, and it might just be spirit, I don't know, but that's our take on it.
Well, gentlemen, thank you so much. This has been absolutely a pleasure. I will be sending a summary of the edited video to everyone here on the panel and everyone here who's participated with us, along with the summary report that I wrote about a week ago on what's going on with Israeli health tech here. So you shall all get that in about a week. Thank you, Todd. Thank you, Andrew. Thank you, Patrick. This was an absolute pleasure to host you. And thank you everyone for joining us, and have a wonderful rest of the day, wonderful rest of the afternoon. And we will see you at the next event.
Thank you very much. Thank you for inviting me.
Thanks a lot.
Thank you, guys.
Thank
Thank
you,
you, everybody.
Thank you.
Thanks. Take care.